how is AI helping you here? I know we're building out AI in all sorts of different facets within the LifeMD ecosystem. I'm curious how you're using it for patient care.
Yeah, maybe I want to pass that one to Amy because she's the guru on this in terms of how we're incorporating it at UVA.
Yeah, and Amy, as you do this, if you want to talk, if it is integrating into research, because that's the next thing I want to talk about is some of the current research ongoing with perimenopause. So, if it integrates, great. If not, we can hit that next.
Yeah, no, that's how I'd probably answer this. So we're using AI pretty heavily. I mean, I think now everyone talks about AI like it's this new amazing discovery. We've actually had AI embedded in our platform since 2017 before it was sexy. No one knew what it was. And I had brains on my slides and people were like, what are you talking about? So now it's like a prerequisite, I think, for any company to incorporate AI in some way. But one of the latest things that we actually incorporated AI in, which I think is quite meaningful for the space, is going back to my previous statement about how perimenopause is traditionally kind of diagnosed with over a 10-year span. You're given the same diagnosis day one as you are 364 days without a period, and tomorrow you're going to go into menopause, right? The clinical diagnosis is quite the same. But our hypothesis was that hormonally, the woman who's starting perimenopause today is very different than the woman that's entering menopause tomorrow, right? So can we somehow map that? And so we really incorporated, we used AI, we built out an algorithm to figure out what is that hormonal signature for women and are there subtypes or phenotypes of women through their hormonal signatures and symptoms that can help navigate that journey. So can we basically put a map to her perimenopause journey? And turns out we can. So this was some research that we actually presented at the Menopause Society conference this year, where we mapped hormonal signatures to the various reproductive stages, and then we're also able to identify subsegments of each of those like macro phases. So a woman like can come in, monitor with UVA for 3 months or 3 cycles, and then we can really, with 88% accuracy, predict exactly where in this 10 to 12-year journey she is. And that comes along with what are the symptoms that you can look forward to, what are some lifestyle modifications to make, what are some questions to have with your doctor. So it's not a treatment necessarily, but it is a guide to help you have this two-way conversation with your clinician. Because again, clinicians like you and Mary are very critical to this entire journey. Women don't want to be an N of one study, but unfortunately, they are. With the current guidelines, you are an N of one. You're going to do a trial and error process. How can we help eliminate as much of that trial and error as possible with data?
So that's amazing that we're able to start kind of nailing down some predictability to this. So give me like a clinical example of a woman who has been helped by this and sort of how that helped her. Maybe you kind of just describe it in very like patient centric terms.
Sure. I can give you a really tangible use case here. So right now, if you look at the menopause guidelines, it is based on symptoms, right? Let's treat the symptoms, and that's what the standard of care is, right? Because again, a lot of the hormone testing is based off of a snapshot measurement using serum. And so you're limited to what a patient can report over the course of multiple days to see if this is somehow related to the transition that she might be going through. So, a very concrete example, we had a woman who was suffering from migraines. She was experiencing incredibly horrible migraines, thought there was something hormonal associated with it, because she started noticing that throughout in specific points in her cycle, she would notice that the migraines were a little bit more severe versus other days, right? Other days she would actually classify it as a headache and not necessarily a migraine, which is a very specific type of pain that a woman would experience, right? So after monitoring with several cycles with UVA, we were actually able to see that when her progesterone was dropping pretty dramatically, the migraines would be a lot higher, and they'd be a lot more severe. Right. And so this actually helped influence her clinician to give her a low dose progesterone. She was already on a low dose estrogen therapy, but with the combination, she was able to actually alleviate those migraines completely. And it brought her hormones back to a balance that was normal for her body. Now, the other thing to keep in mind is that her balance may not be the same as my balance. But when you pair the symptoms with the hormone trends, that's an immensely more valuable data set because now you're able to see how these little tweaks are actually being affecting your day-to-day behavior and symptoms.
Yeah, that's amazing. It is. I've had a number of patients that are complaining of headaches, migraines, and it's not great. It is helpful when you see it line up with something that's happening hormonally. It doesn't help them with their headache initially, but it's something that's treatable. So that is really helpful. And I know so many women are struggling with migraines that can't find the root cause. So man, it would be amazing if everybody could. Mary, are you having a similar experience clinically?
Yeah, I mean, I look over many of the cases that we work with UBA, and I think that what's phenomenal is just kind of seeing whether it's migraines, whether it's I don't feel like myself, I feel off, kind of similar things where we follow these trends. We give the patient and or the clinician that they're partnering with this information or data, and then they shift their algorithm of care, and then we're seeing outcomes change. And so I think that's where I'm really seeing it. Like headaches is one example. Sleep disturbance can be another great example that obviously could be pretty profound in this space. And um, I think I'm just thinking back to what Amy was saying about her study that we did and kind of like mapping out that perimenopause journey. I think the next level from there that I see to potentially be really impactful is what other preventative things can this help us identify or step in at 5 years earlier or 10 years earlier, potentially that could change our outcomes down the road. I mean, you're a bone specialist, right? So it makes me think of like, we don't do DEXAs until people are 65. Well, what if we start to uncover evidence of certain stages during perimenopause? And could we, I'm not saying we should, but I'm saying based on information and data, should we consider screening for women earlier? Because might that impact their new lifestyle and activities that could then change that outcome that we've otherwise just waited until they've hit 65 to find out about, right?
Yeah, well, I think it gives really objective data from that perspective. I mean, even ACOG and the Menopause Society currently say for women going through perimenopause, menopause, you should screen if they have risk factors. But I think so many doctors are unaware of what some of the really common risk factors are, and they're kind of subjective, right? Like, do you have a history of an eating disorder? Well, not technically, but I mean, I have been dieting for the last 40 years. So maybe, like they're kind of hard to nail down. But if you had a number, you could say, oh, well, you're not ovulating and you have, like you do not have significant or any progesterone in your luteal phase as a result of that. We know based off of current research that if a woman isn't ovulating in premenopause, early adult life, they're losing bone if they don't have 5 normal cycles, if she doesn't have 5 normal cycles a year. So then, yeah, that would be a reason certainly to screen and potentially to treat. So yeah, it's very, very powerful tool there. I love that idea. What about more research? Like what's happening? Amy, you and I've talked about some studies, some centers that are really getting into perimenopause research, but boy, it is, if you look at the current research publications that are out there on perimenopause, it is very, very minimal. So what do you, since you're plugged into this, what are you most excited about with research that is currently going on?
I think that there's been a lot more appetite and interest in the space. Obviously, like there is this societal push. You have this new generation that's entering into perimenopause, navigating this transition, and they're very different from the prior generation. Where I can speak for my mom because she said it to me again this weekend that you just deal with it. You go through this transition, and it just is. Um, there's no other solution. I'm like, that's not good enough for me. Right? And that wasn't a concept that the prior generation was okay, like, kind of owning. So, you have this movement that's happening right now where patients are demanding better care, and you have clinicians that were unfortunately not trained with factual research, right? That WHI study unfortunately really tainted the current like breadth of OBGYNs that are currently practicing. And so now you have to untrain that learning, which I think is like we have to be a little sympathetic to the medical community that that is a big thing and a big shift that needs to happen. And you're asking them to make that shift pretty immediately. I don't think that's a reasonable request. And the way I think you can get to the shift of actually being a little bit more receptive to HRT and being able to influence it on your patients a little bit more meaningfully is by having more objective data and research to show the benefits. Like we've been talking about how bone loss and cardiovascular risk and brain health is actually quite influenced by HRT. In theory, yes, but where's the concrete data really highlighting that that is the case and how much benefit you're going to see? It doesn't exist yet. It's still very theoretical. And I think until that theory becomes objective, we're going to have a lot of we're going to be in this limbo phase. And so one of our goals at UVA is how do we start to embrace that objectivity? So we've kind of had it at a micro level of looking at hormone data and trying to like make as many waves as we can. Turns out this is actually quite more critical and is actually enabling a lot of studies to be able to move faster and further and be able to make these broader claims using our data. So I think give it like 3 to 5 years. I think the conversation and discussion and treatment of perimenopause and menopause is going to be night and day from today.
Yeah, amazing. And Mary, anything to add to that?
Yeah, I was just thinking as I was listening to what Amy was saying of like I trained during the time that the WHI came out, right? Like I mean some other people have probably heard this story from me, but like I trained at a time where the WHI came out. We had a big consensus meeting at the organization I was at in residency that was like what do we do all of a sudden? Like how many people are in HRT? What are we going to do with these new recommendations that just came out, right? It was a huge kind of tidal wave in the system at the time. And so now, over the last 20 years since that happened, we've seen the dust settle. It's like you get further past the traumatic event and things settle down, and then you start to reflect, right? So we've been reflecting for a bit, but now I think we're ready to make a new change again. And I think the other part of it as a clinician that I feel like drives a lot of our care is the fear of doing harm, right? And so when that WHI comes out and says, we're giving people heart attacks and strokes and breast cancer with HRT, as a clinician, our obligation is to try and prevent those things, right? So it is hard to change the ideals around something that comes down so quickly and so dramatically, back in the day. And also, we reflect on that time as like we really didn't interpret that WHI data very well, right? Like there was some interesting stuff in there, but what came out in the quick fashion was probably not the full interpretation that needed to be had at that time, right? And now we realize that. And so I think in a similar vein now, we want to create actionable data that's validated, that's evident and evidence-based care, like that's peer reviewed and that we can really scrutinize and show that whatever we said is, perimenopause 3.0 now is actually based on real evidence.
Yeah.
And
Well,
we don't
and
want to make false claims here.
yeah, I mean, this always happens when the conventional system swings really far one direction and gets restrictive. Is that it opens the door to ancillary care providers, and I think everybody means well, except that now you have during the last 20 years you've had providers who are just shunning the conventional system and off doing their own thing based off of potentially very little evidence, which is also potentially harmful. But at the same time, you have the conventional system, which is denying care, which is also harmful. And so it's really tough. And I actually I just wrote something on kind of like the way the WHI was interpreted. Really interesting to go back to 2002, when the internet existed, but we didn't look at papers the same way then as we did now. I started medical school in 2005. So this was, when I started medical school, I was just taught out of the gate, like hormones cause cancer, like don't even think about it. That was essentially my hormone training in medical school. But go back to 2002 when the the study was stopped. There was essentially a press conference. Then the paper was published that same day online, but physicians didn't have access then like we do now, right? When I see something get published online, I can get it. Even though I'm not part of an academic institution, I still have access to it or I can pay for it or whatever. That wasn't the case in 2002. So physicians really heard the press conference and the headlines and then had to decide what to do with all their patients. And I love talking to currently practicing providers in the hormone space who were practicing in the 1990s. There aren't that many of them. But one of them, I will interview her again for this podcast, Felice Gersh. I don't know if you know Felice. She's fun, a wealth of knowledge, but she tells very clearly her story of, she looked at the data and she was not convinced. And she also wasn't using, she wasn't using conjugated equine estrogen. She wasn't using MPA. So she wasn't using the things that were studied. And she was desperate to try to keep her patients on hormones. And the patients also got the same memo and they all wanted to stop. So it was both providers and it was also women who got scared by the headlines and discontinued on their own. And that is not how we should disseminate research. It's so unfortunate. But I agree that the WHI did. It was a well done study in a lot of ways. There is a lot of data that we can get out of it. We can continue to use it, but now we have better objective data. We've learned so much from the mistakes of the research in the past, how we can design better studies now. So then to circle back to this perimenopause picture, what do you hope that we're going to see? Maybe just give me a couple of like clinical case examples or clinical use cases. What do we hope we're going to see coming out of this research? What can women look forward to?
Yeah, I really think, and maybe I'm selfish in this space too, because I'm a woman in perimenopause, right? So I'm highly motivated here. But I would love, I've seen thousands of patients for this same kind of presentation of like, here's the symptoms that I'm experiencing. And I don't know what to do with it. It's usually, and they're still cycling, they're still having periods, right? But they're having hot flashes, sleep disturbance, oftentimes gaining weight, severe PMS, maybe headaches, bone, joint, muscle aches, like all of that kind of like laundry list of symptoms. And how can we, based on data, help them through these symptoms, right? Like we are kind of in this gray zone of like, well, you're still having cycles. So, like the kind of like more traditional thinking was you're still having cycles, so you still have enough estrogen. But now, as we dig into knowing kind of more of what's happening with our hormones in this perimenopausal space, like, yeah, we're still having cycles, but our hormonal levels can dramatically change day to day. And that can lead to a lot of these symptoms. So, how can we help women navigate this journey in perimenopause and not just waiting for them to hit menopause? Or maybe the flip to that is like, is it birth control pills until you're menopausal and then it's HRT, right? Like, let's try and bring this to a next level for these women, right? Like, let's help us understand. And I'm not even saying help them understand. I'm as a physician too. I'm like, help us understand kind of what's at the root of these various symptoms and what are all of the options that we can offer patients. Because if we've got one option, that's pretty limited, right? So it's really nice for people to understand what's going on, and then as a clinician and a patient kind of making that educated decision of next steps based on all of that information. I see that is a huge gap of, just understanding research, evidence-based care, that we're in right now, that we could really make tremendous leaps and bounds. And I think both hormonal screening as well as like AI based technology could help us, instead of waiting another 20 years to figure this out. I think, like Amy said, I think we could really dial this in significantly in the next 3 to 5 years.